Thank you. Thank you for joining the webinar today. In the month of September, we are looking at the Childhood Cancer Awareness Month. And today we are very privileged to have our speaker, Dr. Michael Magoha, and we shall be going through a topic on the overview of childhood brain tumors. Dr. Magoha is a consultant neurosurgeon and a lecturer at the University of Nairobi, Kenyatta National Hospital, and also at the Nairobi Hospital. He has done training in medical education, surgical leadership, neuroendoscopy, and neuro-oncology. He's also one of the founding members and immediate outgoing Secretary General of the Brain Tumor Association of Kenya, an association that is ratified by the International Brain Tumor Association. Dr. Magoha is also an author. He has authored a very good book for learners, effective learning methods for learners. And apart from that, he's also a very committed member of our multidisciplinary team at Kenyatta National Hospital and University of Nairobi, where we manage these children with brain tumors together. So it's our privilege and honor to invite you, Dr. Magoha, to take us through the overview of childhood brain tumors this afternoon. For the members, feel free to put your questions in the Q&A section, and we are trusting we are going to have an interactive learning session today. Karibu, Daktari.
Hello, everybody. Can you hear me?
Yes, we can hear you.
Thank you so much, Dr. Nzamu. You're making me blush. Let's get right to the presentation. Can everybody see my screen?
Yes, we can see your screen, Daktari.
Fantastic. Thank you. Thank you. Now, we'll be going through pediatric brain tumors. As was mentioned, my name is Dr. Michael Magoha. I'm a consultant neurosurgeon. I work at these facilities that you can see over here, University of Nairobi, Kenyatta National Hospital, University of Nairobi Neurosurgery, and that's a private entity that I work with. I'm pleased to take you through introduction to pediatric brain tumors. Now, before we move on, we need to set the stage of to what to expect and what to do. I need to be quite clear. There are over 120 types of recognized brain tumors. And with all of those brain tumors, they have different things which are noted to be significant and not significant. So with that, we'll never be able to go through everything. I want that to be quite clear. However, what can I do to this mixed group? What I can do to this mixed group is I can prepare you so that you can manage brain tumors and all the different cadres. And most importantly, you can understand an overview of all of the brain tumors. With that, let's get started. If you have any questions, please leave them to the end. There's no such thing as a stupid question. Do I have anything to declare? I have nothing to declare. Now, let's first set the stage. Oh, sorry, somebody's moving my slides.
Recently, Scripps News Grand Rapids introduced us to Anna, Luke, and little Paxton Floric. He's our walking miracle, absolutely. Good job, bud. At 10 months, Paxton had a golf ball-sized tumor at the base of his brain and spinal cord. The cancer was rare. His prognosis was bad. Remarkably, he beat the cancer. His healing continues.
Doing PT right now, but does OT right now, doing feeding therapy right now, school 2 days a week.
Because pediatric brain tumors and the treatments to fight it can impact how a child grows.
They're developing, their bodies are developing. And when you put drugs and they can't go to exactly where they want to go, it causes problems and on their growth and their brain development and other aspects of their childhood.
Okay, so this sets the stage. Why am I showing you this? There seems to be this opinion that whenever we see a brain tumor, that something is rare, or even the issues with management tend to be very complicated, and that we can't seem to manage them here. But what this illustrates is this is quite normal everywhere all over the world. Everybody seems to have the same issue. And I want you to note the gravitas of the problem that we have to deal with. The issue is not that the child has a brain tumor. The issue is that it is a child who has a brain tumor. That means the child has to go through secondary brain development, and the child has to grow up. They have to figure out who they are. They have to learn different skills. They have to develop cognitively. They have to develop physically, get kinesthetic intelligence. So all of that can be affected by the brain tumor itself. And I want you to keep that in the back of your mind. It's never as simple as just going to remove the brain tumor. The thing is, what are you going to do to this child's life? The second thing which you will go through is the decision, depending on the type of brain tumor, how the approach to management will be completely different for all of them. And hopefully with this, you'll understand why neurosurgeons are a bit hesitant sometimes to manage tumors in ways which everybody else might think should be straightforward. Okay. Okay, there you go. So this is borrowed from ASHO. If anybody knows what ASHO is, it's an American Society of Hemato-Oncology. And this is generally what they expect somebody to know when they're talking about brain tumors. So I'll go through it systematically. This is how you should read anytime you want to read about any brain tumors. You need to understand, let me get a pen here for you. Hopefully you can see my pen. So we need to start with little basic science and pathophysiology. That has to be there. That's a basic tenet. This is mostly where undergraduates tend to spend most of their focus, need to understand where the brain tumor comes from. Then next, this is epidemiology and risk assessment. And for that, you need to recognize patterns of health and disease. This is something that people don't realize. It's a difference of putting research into action. What does that mean? It means wherever you're working at, whichever center, you need to pay attention to what is important or what tends to be prevalent. And in doing that, you'll be able to identify risk factors and identify conditions for good outcomes and poorer outcomes. So you need to pay attention to that when you start practicing. The other one, which everybody thinks the medics tend to do, is diagnose. You will diagnose. The good thing is, no matter what happens, as long as you follow the correct guidelines, you will always diagnose the patient. So that's just using available information, and it starts simple. Patient history and physical exam. It doesn't mean jumping straight to the CT scan. Those two alone will let you know what we need to do, especially at the time at which you see the child. So one of my colleagues from postgraduate, Dr. Tracy John, wrote about early diagnosis and treatment of children. I urge you to read that. You can find it, I think, at the EJNS, and I think she wrote a book about it as well within our country. Next is management and treatment, which is where everybody thinks we're going to focus, and that's formulating comprehensive management and treatment plan, including reevaluation of long-term follow-up. This is where I find locally we tend to miss. Once they're out of the hospital, we tend to forget and think that they're okay. Everybody's guilty of this, not just neurosurgeons. And I'm sure as the burgeoning oncology community can attest, that seems to be the brunt of their work. They tend to be forgotten. All right, but what are we going to do? That's what you expect. That's what ASHO tells you to do. But all of that is at least a minimum 3-month course guideline in rotation in neuro-oncology. We don't have that. We have about an hour and a half. So with that, what are we going to expect? Well, it's generally the same thing, not in as much detail as I would like. We'll go through the clinical presentations, but I can't do that for 120 tumors. Everybody would fall asleep and they wouldn't know. Next is diagnostic imaging. We can't go through all of that. It wouldn't make sense. I can't put 1,000 scans here and say, use for this one, you see this, you do this, you do this. There would be no point of this class. I would just give you a textbook and go do that. You will also see the pathology. And the other thing which is important is the other laboratory tests. Those are the things we need to pay attention to. So what am I going to do? I'm going to give you how we should move through this. Every time you see a child and you suspect that there might be a brain tumor, how can you be an effective member of the team? And better yet, how can you increase the quality of life and help treat the child? So this is what we're going to do. We're going to discuss general CNS tumor epidemiology and etiology. You're going to get your usual neuroanatomy lesson. We're surgeons, so we love anatomy. But most of you here have forgotten or you hated neuroanatomy, so I'll make it as simple as possible. Next, the main thing is, why are brain tumors bad? That's the simplest thing you have to understand. Classification, I put it there, and I thought I put a slide, but when I kept going through it and I tested the presentation, it made no sense towards people. I think what's more important is understanding why. I'll just write a why there. Why we classify. And then from there, we'll discuss a couple of specific CNS tumors that you'll see. And what I personally think is the most important thing, and let me emphasize it, I shall draw all around it for all of you, is patient pathway and conclusion. Because unless you leave with something, you're doing nothing. There's a general overview. This is why I like pediatric oncology. Look at this young little girl. This is a child who has no idea what's going on with life. She's super happy. She loves flowers. If you're getting stressed and you don't know why to read or why to study, imagine a picture like this. You always give somebody like this a chance. So this is why I put this up. We start with a general overview. You think about it, and then you remember. So what's the introduction to brain tumors? Here's the thing. I mean, I'm not talking badly about any of my colleagues, but they have done the work. Neurosurgeons were low in number, so people don't realize the work. And what is the work? Everybody in this group knows about breast tumors. You know about cervical cancer. You know that all people have done research all the way until now, you can vaccinate against things like cervical cancer. We're talking about vaccinating men to prevent development of cervical cancer and penile cancer. All of that is research because it's common. When you talk about brain tumors, we have an issue of misclassification. Everybody thinks that, brain tumors are rare. If you open your pathology book, they say 1% of tumors generally, but that's not our data. The problem is, the second problem in misclassification is, you're talking about that generally. When it comes to children, CNS tumors are the most common solid malignancy, and the second most common malignancy overall after leukemia. So if you want to effect change, what's the one thing that you can do? You can start looking at CNS tumors in children so you can start changing people's lives. And what happens with them? Astrocytomas are the most common brain tumor overall, and they're mostly low grade. What does that mean? I'll explain to you right now. An astrocytoma, from the name, comes from astrocytes. They look like a star. They're these little things, think of it almost like connective tissue of the brain. It touches one nerve to the other nerve, and it's all over. So if those cells start to rebel and grow without order, you get an astrocytoma. The good thing is they're low grade. Brain tumors are classified from low grade to high grade, grade 1 to grade 4, based on the same things that you always say. What are the same things that we say? We talk about vascular proliferation. We talk about mitotic index. We talk about being able to tell the original cell that it comes from. So we talk about nucleotypia. And then you talk about the cellular differentiation. So if it's a yanni, you're saying it's a cell that grows, it becomes the same. The other thing that they have now is medulloblastoma. Everybody has heard of astrocytoma. The one everybody has heard of is medulloblastoma. It used to be called a small blue tumor. It used to be mistaken for a what is this? This other neurocrest cell, I forget, it will come to me. But medulloblastomas are the most common malignant brain tumor. So more context, grade 1 to grade 2, if you're able to remove the whole tumor, you have achieved cure. Grade 3 to grade 4, tumors, even though you remove the whole tumor, no matter how, I'll speak locally, no matter how gangster you are, you remove everything, it still comes back. And historically, people have done what would sound like crazy things, but at the time, it was where science had reached. People have done lobectomies, people have done hemispherectomies, but still, after you do that, the tumor grows in another place. So that's the thing to keep in the back of your mind. All right, so the same thing is, what's the situation locally? Like I've told you, it doesn't matter saying all those things. Remember, you have to know about where you practice. So this is a publication I did with two of my mentees and our chief neuropathologist, Dr. Okemwa here. This was changing trends of brain tumors at the Kenyatta National Hospital, and showed us a very simple picture. The most common tumor was glioblastoma all around. The other thing of note is about 30% of tumors that presented at the facility over that period. Keep in mind, those days we used to have about 2 theater days, maybe 3 theater days. Now we have 5. We have a running theater. We had roughly about 1,000 and something patients over that period. So the number has increased significantly, almost a 4 to 5-fold increase. So the numbers must be a lot more now. So I urge anybody else, if you want to do it now, you can start doing this and follow this. The journal is the East African Journal of Neurological Sciences. I urge anybody with anything to do with neurology or neurosurgery to also send to this journal. Buy Kenya, build Kenya. We have to build ourselves. The other thing that happens is this surgical outcomes of pediatric brain tumors in sub-Saharan Africa systemic review. It shows the same thing. About 30 to 40% of tumors that are presenting are pediatric brain tumors. So it is a big issue. It's just that we're not looking at it. So what about internationally? So I beg your forgiveness. I looked for the CBITRA study, which was closer. This is the closest one I could get. And it shows you the same thing. You have all these different types of tumors. People stop sending me messages. Sorry. And what you see, a large chunk of it are these. These are the aggressive tumors, unfortunately. You have other things like lymphomas, pilocytic astrocytomas, which are grade 1, embryonal tumors, which are aggressive tumors. All other tumors, because I told you there are over 120, mixed glial tumors, meaning when you put under the microscope, you can't even tell where they came from. Epidermal tumors coming from the linings of all of the ventricles. Nerve sheath tumors, as it says, from the sheath of nerves. Craniopharyngiomas, these are remnants from the Rathke's cleft. These are benign tumors with malignant behavior because of embryology. Pituitary tumors, which we will speak about. Germ cell tumors, which I honestly feel we need to have our own time and discuss it significantly. Glioblastoma is the one thing everybody pretends to understand, but we do not know. Meningiomas are very common. 3 in 100 people will develop a meningioma in their lifetime based on autopsy studies. So if you're about the age of 70 or so, you might have one already. It doesn't mean that we have to operate. Oligodendrogliomas, which are the ones that we used to think they were benign, then we think they're aggressive. And now in the molecular age, we're not sure what they are. But we'll go through it. I put this slide to show you something funny. So the thing about neurosurgery is you can read as much as you want. You can die reading. Our standard textbook costs about 24 kgs if you want to ship it in. So we tend to have little funny tables like this in our textbooks, like clinically important brain tumors. So these are what people have decided are common. So you need to know this. But the problem is there are many others which are still significant. So as a neurosurgeon or as an oncologist, you have to be aware or prepared to see them, that there might be some people might not be ready to deal with. The other strange thing that you must be aware of, since we're talking about Kenyatta National Hospital, I'll say something that happened in Kenyatta National Hospital that people might not be aware. The words that my seniors like to say are gurus. So one of the gurus in the world, a lady called Anne Osborne, there was a type of brain tumor where less than 100 of them were found in the world. And that type of brain tumor, to get it, it looks like a glioblastoma, but it has to affect more than 3 lobes in the world. I believe one of the first top 20 cases was found in this hospital of ours, known as Kenyatta National Hospital. Now, that was known as gliomatosis cerebri. Unfortunately, with our reclassification, and remember the thing about reclassification, whenever we classify something, it means one of 2 things in medicine. Either we fully understand it, or we don't understand it and we're trying to make sense of it. So if it keeps changing, it means we're getting more information. And unfortunately, it was reclassified, and gliomatosis cerebri has been removed from the textbooks. So Kenyatta was already there worldwide in neurosurgery, but now it's been removed because of that. We need to bring it back because of something else. Now, here's the next question everybody will ask you. Every neuro-oncologist will be asked this question. Every neurosurgeon will be asked this question. Daktari, why did we get this? Number one, start with brutal honesty. We don't know. For a vast majority of them, we do not know. And I need to be very clear. We do not know. But what we do know is there are some associations. The problem with these associations is they're common sense associations. And the easiest way to tell once we fully understand, I give a perfect example like smoking. Anybody who smokes or saw cigarettes, it used to be cigarette smoking may be harmful to your health. Then it became cigarette smoking kills. Then now it became, oh wait, it's not just killing. They put pictures on what will happen to you if you smoke cigarettes. Now, what that shows you is because of lots of science and lots of literature, you can calculate things like pack years. And you know, anybody with over 20 pack years, you are getting something. That shows progress and that shows something to avoid. Everything that we're telling you for brain tumors, it's general. There's nothing much I'm telling you. Ionizing radiation, fine, you knew that. That just basically means when the cell is dividing, yani, there might be some energy which will come and hit the cell at some point. And as it hits the cell at some point, it will divide badly and start growing badly. Easy. That's the same for everything. What are the specific ones? We can't tell you at present. The other one is genetic or brain tumor predisposition syndromes. These are the ones of, if you want to pass the MCQ, it's the same ones. There's nothing you're memorizing, P53 mutation, etc. Now, with that, you will still be asked and you still have to pass some questions. If you go do something for oncology, they ask you, what are the risk factors, Daktari? They are direct risk factors. These are some that you must know. If a patient has this, they are going to develop a tumor. And these are the tumors that are known. Here's one I must confess. I never knew this disease existed before I did neurosurgery, and I didn't think it was that common. Neurofibromatosis, type 1 and type 2. Neurofibromatosis type 1, they always get low-grade gliomas. Most common is optic pathway gliomas and brainstem. Now, I need everybody to take a deep breath. And remember and think about what we said. A low-grade glioma, you can achieve cure if you remove everything. But none of you will want me to go and remove the optic nerve of your child, or worse yet, the brainstem of your child, because that makes no sense. Once you start to think like that, you understand how neurosurgeons pause, and every individual case needs to be case-by-case basis. From there, we go to neurofibromatosis type 2. The genetic abnormality they have is NF2. They commonly get things like bilateral acoustic schwannomas. They get multiple meningiomas and multiple ependymomas. They also have increased risks of other things like cataracts and seizures. So that's why they'll come to you. Tuberous sclerosis caused by TSC1, TSC2 gene. They get things like SEGA, subependymal giant cell astrocytomas. That one is fine. From a good history and a good scan, I can achieve cure and look like a hero. However, what is the point in knowing all of this? Even though I remove the brain tumor, they have other things which are coming to get them, which is why we disturb you with this. And this is why when you talk about pediatric tumors, don't concentrate so much on the head. Figure out what is going on with this child. What are the things that you can avoid? So for anybody in any CADA, you hear brain tumor, just pause and be like, okay, is there anything else going in the child? Do a full exam. Look at their skin. Check the kidneys. Look at the full blood count. Look at the UECs. Don't just skip and look at the scan and say, call neurosurgery, because you might not be helping the child in the long run. Here's the one for if you have a stuck, say, Lifraumeni T53 mutation, you'll get everything malignant because you can't stop. I mean, you can't apoptose dangerous cells. So you get all the West cancers, malignant gliomas, choroid plexus carcinomas, which are super rare, less than 1%. Why is this child getting it? Look if they have Lifraumeni. They'll get numerous cancers at younger ages when things are dividing more. They'll get stranger cancers like breast sarcomas, adenocortical carcinomas. Why is this important to know? This is a position to stop, because if you ever see a patient who has a cancer and it's not following the normal rules, you need to pause and think, wait, do they have something? That way you'll be saving lives and not just reacting to the cancer itself. The other one, which is Gorlin syndrome, you can get things like medulloblastomas and basal cell carcinomas of the skin. Familial adenoposis coli, you know what it happens. They'll get colon cancer, but what will you see when they're young? You'll see medulloblastoma. So if you see a child with medulloblastoma, the father had colon cancer, or the father had polyps, start thinking, do you have something like Gardner's or Two-Coats or any polypoid condition? You will help them in the long run, because fine, his medulloblastoma was removed when he was 10, 15, you're seeing him in the clinic. Tell him to go do, sorry, that seems a bit vulgar. I think you know what I mean. Endoscopy, colonoscopy. Then you have things like rhabdoid tumor predisposition syndrome. These things, you get things like ATRTs. These are super aggressive tumors in young children less than 2 years. It's going to be a fight for the rest of their life. And for that one, you have to have a clear discussion with the family. You have to talk with religious leaders, etc., because it can be taxing to the family, economically, emotionally, mentally, and these are things you have to think of. For any of our ophthalmologists in the house, the same retinoblastoma gene, which causes all of the same osteosarcoma, etc., will give you trilateral retinoblastoma, which will be associated with a pineoblastoma, which is rare, but often diagnosed below the age of 5. So you see how we should always work as a team. Don't always think of the scan. That's what I want you to keep in the back of your head. Now, I promised you the most basic anatomy lesson. So all the anatomists in the house, don't laugh at me. This is the frontal lobe. This is the parietal lobe. This is the occipital lobe. This one is not labeled, so I'll help you. This is the cerebellum, which does movement. And then this is the temporal lobe. And this thing here is called the brainstem. We just group all of these together. When we say there's a brainstem lesion, we might not really care what part of the brainstem it is, because either way, everything will go through the stem. So when you're dealing with it, you have to be very clear if it's something you can deal with or something you can't deal with. Why have I put this basic diagram here? The best thing about brain tumors and neurosurgery, you don't have to memorize how things present. You just have to look at the presentation and figure out where it is on the cortex. And there are things that are cortical and things that are not cortical. But for you guys, what do you care about? What do you want to see? Now, after lots of research, we found out that this line over here, which I've marked for you, yeah, changes everything. Everything, how they'll present, how they're moving. And that makes it if it's supratentorial or infratentorial. Funny thing is, even the drugs that you'll give, even the radiation that you'll give, If it's supratentorial, most of the time, we have a bit of a chance. Yeah, you can move. The surgery might be easier. Yeah, you can irradiate a bit more. There's more space of brain. There are things like neuroplasticity, which can save you. Then we have infratentorial. This is a bit horrible. Let me illustrate a simple point that many people not dealing with the brain might not realize. So everything infratentorial is in something called the posterior fossa. Posterior fossa is a small space. It always looks big in pictures, but I always urge people, touch the back of your head. And if you touch from the occipital protuberance to that little dimple in the back of your head, for example, for mine, it's this big. It is never a big space. So what does that mean? There are things, when it comes to posterior fossa lesions, they call it there are 2 phases of development. So you have the initial rapid phase where a patient is symptomatic. So they will get something like cerebellar signs, etc. There might be central or peripheral cerebellar signs or lobar cerebellar signs. That happens until you reach a point of equilibrium. Then you have the phase 2 of development. Phase 2 is rapid decline. Now, the issue is that space, I don't know. Yours, mine, everybody else, every child is different. So just because you see someone, they're smiling, if they have a facial nerve palsy or if they have a bit of ataxia, it doesn't mean in 2 hours they're not going to just drop and you have to intubate them. That is why I tell you about phase 1 and phase 2 of development of posterior fossa lesions. The other thing I'm going to say here is something that might come as a shock to some people. Any posterior fossa lesion is a neurosurgical emergency. Now, let's do the math. We have said worldwide, it's the most common tumor, most common solid tissue tumor. It's only after leukemia. So if you're in a country where people tend to refer, you will be inundated by these posterior fossa lesions. So if you're inundated, then you have to develop different tactics to buy time. So like things like shunting, etc. Now, I must be very clear, and I will speak the truth. This is not a normal practice. It is because we have more cases than other places. So we do things like we put shunts, we tell them to do MRIs, we buy time. The average surgery will take anything from 3 to 6 hours. So even if you have 60 patients, that's not going to happen now. That's months of work. So you do realize it's a system issue. How do you address system issues? The same thing we said from the beginning, identify that this is a problem, and we sit down, multidisciplinary teams, just as we're doing, starting now by highlighting the issue, and we will get a way forward. So this is why I'm very happy this is happening. Okay, so this is what I said. Here are a couple of the ones that I put. So these are the ones that I put. These are the textbook ones. You need the ones for the MCQ. What is there that you're going to say? So frontal lobe, you say personality changes, decreased motor speech, Broca's seizures, temporal lobe seizures, poor memory, language comprehension. Wernicke's, this is significant in children. Do you know why? People will just be saying, my child is slow. Just lingering the child, shouting at the child, saying that, oh no, he's just the way he is. They could have a tumor that's growing very slowly. Yeah. The next one is parietal lobe. So decreased sense of touch, pain, poor spatial visual perception, poor interpretation of language. How will that look in a child? You look at the child, they're just not grabbing. You think your child is taking long to develop. This is the thing. This is why things like well baby clinics are very good. So that you hit hard, you hit fast. Occipital lobe is common sense, poor or loss of vision. However, if you have a child who takes long and can't communicate, it will take you long to realize this. So I need to, at the back of your head, always think, how would a child present like this? This one is common. Also, posterior fossas are common. So you'll see the child having a problem with walking, or the personal favorite that pediatric pediatricians like to write is regression of milestones. Which ones? Just tell me which milestone has been regressed. Stop writing that line. It really annoys me, as you can tell. Next is the brainstem. When you see this, we start getting a bit scared. And now let me illustrate something. It starts the same way. Weakness because of the pyramids. Next, you'll see multiple cranial neuropathies. The best thing I need to teach anybody here who's not from any cadre, the fastest, best way to examine any cranial neuropathy, these 2 things here, the eyes. Just look at the child and just see. This something feels off, ask someone. You will notice what it is. Then here's the one that everybody misses and everyone starts reacting to, autonomic dysfunction. And someone say, but doc, autonomic dysfunction gani? The same ones. Unexplained fevers keep happening. The child is just sweating. Unexplained weight loss. Then you start thinking, oh my gosh, this child has a tumor. So you will get this time and time again. A child is treated for meningitis and this for long, more than 35 days. And then somebody is like, hey, what's going on? Yeah, you do a lumbar puncture by the grace of God. You get one or you get those 1 or 2 drops, so nothing happens because nobody looked in the eye to check because nobody has the fundoscope. And then you get a few drops. What is that? That's Jesus protecting you from you missing. Later on, you do a scan, you see there's a brain tumor. So what is the point of me telling you all of this? There is never any shortcut. If you're inundated, you make the system work and you work with those who are close to you. All right, with the next thing is the thalamus. I find most medics are never sure what exactly the thalamus is. Think of the thalamus as simply a control tower. So it looks around, it's getting all of the sensory information, and when it picks all the different types of sensory information, it decides what to do with it. And there are many things, so it could be like weakness, telling you how strong to move something, motor control, telling you how coordinated to do that, consciousness, saying, hey, my guy, let's not use the reticular activating system right now. You need to just forget what's happening. That could be anything, even emotional stress. Sleep-wake cycle, same thing, you're tired. Or better yet, you're active, you're ready, you have to focus. Your thalamus is the one deciding and helping you with that. Then just below your thalamus, just under the boss. And think of it this way, God in his infinite wisdom made everything for a reason. Your thalamus is the control system at the top. Anybody who's a boss, what do they have? They have an underling, the KYM, the Kazi Mkono. Any of you guys are about to finish your residency, you will go into the consultant and say, hello, please, sir, just give me a few drops. That's the hypothalamus. So when the thalamus is there doing everything that's cognitive, everything that's reflex, your hypothalamus is doing. So things like temperature regulation, thirst, hunger, deciding to secrete hormones, your boss doesn't care. He doesn't want to care about it. Leave the small guy to do it. That's the hypothalamus. All right. Now, this was supposed to be a test, and unfortunately, I see my things haven't moved. So here are a few things. New onset seizures, you look for things like the temporal lobe. Visual acuity, optic pathway. Left side arm weakness, right motor cortex. Swallowing difficulty or drooling, think brainstem. Ataxic gait, cerebellum. So I just summarized for the most common ones that you will tend to see and where you need to think immediately. Now, next we go to low-grade gliomas. Now, here's the thing. This is the glioma, and let's keep going through the same thing so you can understand. So like we said, low-grade gliomas, you remove the whole thing, you achieve cure. So this is how we're different from other surgeons. We don't do wide margins. So we do this thing of how much can we remove? And you can see, if many of you can see it here, let me draw. This is the tumor right here, right there on the left side, where all the important things are supposed to be. So like I told you, astrocytes, astrocytomas, think of them kind of like the connective tissue. So if it's the connective tissue, it tends to push the nerves away. So when it pushes the nerves away, we will ask you for some tests like tractography, etc., to plan. It's not hard to remove the tumor. We remove the tumor, then what? This person can't talk, they can't move, they can't learn, they're a child, they can't coordinate. What have you done? So that's why we think of it like that. The next thing is, have this in the back of your head. I think I shall have some visual aids. Tumors tend to be like uji. So you just go and you suck uji all the time. There's normal brain, and then there's that one that's uji, just there. And as we keep moving, the science keeps changing. This was said at a previous meeting over the weekend, and I'm happy somebody said it. It was one of our senior consultants who was saying the things he learned in residency sound archaic now, like nobody would do them because of the way science has changed. And that's just low-grade gliomas, and that's a period of 10 years. And he is true. So low-grade gliomas, thank goodness, is the most one. So those are things. That's all the size X for you here. The best one means hair-like. When you take that thing over there under the microscope, you'll see multiple hair-like cells. It's not pilocystic, it's pilocytic. Now, since it's multiple hair-like cells, if hair lies on itself, if it's a very tiny hair that you can't see with your own eyes, imagine it's going to look like it's fluid. So that's a nice one that you can remove if you look like a hero. Everyone's like, oh my gosh, I removed a brain tumor. But the neurosurgeon knows that was basic work. Now, here you go. So what are we talking about? We said they're the most common tumors in childhood. So if you want to effect change in the world, not even the world, now in Kenya, imagine start looking for low-grade gliomas. That's it. Look for this thing. That's 50% of all the tumors that you will have in the world. The other ones are the ones you've heard of. Medulloblastoma, everybody here has heard of that word like once or twice. Craniopharyngioma, you've also heard of that once or twice. Epidermoma, you've heard of once or twice. The one we don't want to hear about, because it's always going to be a sad story, is ATRT. Till one day, it's not a sad story. Keep in mind, there are 120 different types of tumors that even the oncologists here must know. So where are they? They're hidden somewhere over here. Some small number for now until something changes in the world. Okay. Next, what is this? This is another example of astrocytoma, subepidermal giant cell astrocytomas, which are very common in children with tuberous sclerosis. These are treated with, to be honest, nobody knows everything. I did surgery for a reason. All I know is mTOR inhibitors exist. How much are they? I don't know. All I'll do is I'll call my very able colleague like Dr. Nzamu, Dr. Irene Nzamu, and she's going to go and find that out. But I must know it in the back of my head that sometimes I don't need to treat with surgery all the time. Also, regardless if it's Schilling's positive, regardless if it's an easy, straightforward case, think of the life of the child. Okay, so now this is a picture. Now, I put this to illustrate. So in medicine, okay, let me see where to start. Okay, I like to read about the brain a lot, and I tell anybody I teach, I tell them about cognitive biases, because one thing about teaching is losing cognitive biases, which are these shortcuts that you use in the head. And one of them is called base rate neglect. Base rate neglect is very common. It's one of the most common things in medicine. The other way people say it is, you only see what you've read. It's that simple. So when it comes to these diseases, here's the problem when it comes to classifying. We're talking about things you can achieve cure, things can change people's lives. But how do you even find out about neurofibromatosis? Herein lies the problem. These are the things. This is why I didn't do internal medicine. I don't like scoring systems, but they are here. So if they have 6 or more café-au-lait macules, 0.5 mm in children, the problem with this café-au-lait macules is they present at different ages. If you don't know that, you're not going to see them. It's literally that simple. They're going to start from the ages of 10 to 13. So even though you have a child, you're not going to see it. If you see it, oh, this is aggressive. Next, subcutaneous neurofibromas, which can be plexiform. We have these all the time, but everyone says the same thing. What's that growth in the child's head? What's that growth? And then they do a scan. Hey, there's a tumor in this child's head, guys. There's a tumor. It's the same neurofibroma. They have neurofibromatosis. Attack the cause. Don't attack the symptom. Then axillary and groin freckling, optic pathway gliomas, leash nodules, bony dysplasia, and first-degree relatives. So just a good history. 2 or 3 of these is enough to diagnose. You don't need to have all of them. So these are some patients who had, these ones are aggressively overt neurofibromas. These are what we like to call, Kenyatta patients. By the time they've come, you're out of the textbook. You're in new ground. And that's not a bad thing. That is how the world will know who we are. It's not to treat them all the time. It's to treat, right, and teach the world. So this is what happens if things start growing really, really fast. So you'll see this. Everyone will be focused on the face or the skin. Something will be growing in the brain. How do you help this? You diagnose earlier, you start the different treatments earlier. You don't wait until this starts to happen. I can tell you this, none of them were born with these. They start at different years, 5 years, 6 years, 10 years. So you're never out of the woods yet. I'll say something very quickly about this. I've already told you this. 20% of NF1 patients will get low-grade gliomas. Biopsy is not necessary. It is a classic appearance. They can be asymptomatic or indolent. Treatment is only initiated with visual acuity decline. Why do I say this? If you don't get a good history, you'll just have a patient. And I say this also for any neurosurgeons on the call, because I have to tell my residents. You'll go there, you'll see a scan, you'll get excited. Straightforward brain tumor. It's time for you to be a hero. You go, very quick surgery. You come back. Now, this is how it will come. If you don't have any knowledge, people will say recurrence. If the pediatricians, oncologists don't trust you, they say, hey, doc, you didn't remove the whole tumor. Next, you start going repeated tumors. If the patient didn't have any faith or didn't believe in you, what will they do? Exactly what you would do. They go to another neurosurgeon. Now they start this long pathway. Then before somebody just comes and pulls under their axilla, sees freckling. Does anybody in your family have random growths? And then now you know, hey, sorry, you're going to keep getting tumors. It's this and this. These are the treatments that we can offer. Yes. And you're not taking lots of money from them. You're not wasting their life. You're not doing, you give them a chance to live. This is why a little bit of knowledge goes a long way. So how do you do this? Any patient with a low-grade glioma, do not attack the glioma. Ask yourself, why do they have it? Simple. All right. Now, chemotherapy is the first line in children in NF1. It's associated with low-grade gliomas that require treatment. The most common chemotherapies are the same ones, so you need to send them straight to your oncologist first. You avoid radiotherapy in NF1 patients because the secondary exposure from ionizing radiation will stimulate more growths everywhere. So please note, do not send the low-grade glioma that's recurrent to radio-oncology. Please note, any radio-oncologists in the room, tulia kidogo, listen, stop. Otherwise, they'll come back 4, 5, 6 tumors. Most of the time, if any of you are residents and you do it, they won't come back to you. They'll come back to the guy who's below you, and you're like, why do they have so many? Let's write a study. Nobody took a good history. Okay? All right. There you go. This is a typical symptom thing that you have. These are real patients. So young patient, MRI is done. They couldn't see with one eye. You do a scan. In fact, you don't even have papilloedema. You have optic atrophy. You come and you see this. This is an optic pathway glioma. The problem with this is inaweza anza hapa, but optic pathway, it goes here, goes like this, it goes here, and then it goes here. The thing I want you to realize, anywhere here can be the epicenter. That's why it's important to know optic pathway gliomas are a differential for cellular lesions over here. And how will you know? It will be hard to tell sometimes. You'll just go in, it looks like it's arising from, or it's engulfed the optic nerve. Any surgeon will think, it's craniopharyngioma, pituitary macroadenoma. They just start coming, they're moving. Then they realize, I don't see the optic nerve. It's because you are in the optic nerve. If that happens, don't panic. It happens to everybody all over the world. The patient was already blind. The thing that you have to understand is it means you have to stop the surgery there. This lesion is infiltrative. It will go all the way through. No matter how much you remove, it will be going all the way through. So it has its own way of managing. Things like tumor debulking, etc., don't make sense because it's already a low-grade glioma. So who will have the answer? I don't know, but somebody will. This is the other one. Now, this is the one which is more common. I'll go back so you can see. This one I've labeled for you. It's big, eh? It's white. It's straightforward. Yeah, anybody can see it. Wow. Here's the one that you don't know unless you know. This is a sad one. It's a young child. They call it railroading. If you look, 1, 2, 1, 2. This child has bilateral optic pathway gliomas. Now, from what I've told you, go look for things like NF1, etc. Ask the family. Tell the family, do they have any family history? These are the ones that you have to send for genetic counseling. Nowadays, they can be done even locally. It's about 25,000 shillings for the general panel. If they want something else, you add. Pediatricians will be better placed to tell you than me, but it's up to you as the first person to see, to say this has to be done. It is not normal to have more than one tumor. This is a real life case as well. So these things are not just things in the books. And how do they present? Child just not seen. This one was caught early because the pediatrician had a high index of suspicion. So they helped this child. What do? If it hasn't spread backwards past here, they're already not going to see. So it sounds bad, but you have to everything. They might not see, but they have a chance at life. Okay, so here's the diagnosis of biopsy with the goal of complete resection whenever possible. One of the exceptions, I've told you about NF1. Typically, it doesn't spread to other parts of the CNS, but unfortunately, if it spreads through the optic pathway, it's the entire optic pathway. We don't do lumbar punctures for anything where you expect there's a growth in the brain, except for posterior fossa tumors, which we will talk about. All right, let's go. Now, everything I told you sounds scary, doom and gloom. So I went to check and see if anything is there so I don't start telling you old things. Here's one new thing, and that means already this has told me, hey guys, the classification of brain tumors is going to change again. I don't know when. Hopefully it's 5 or 6 years. So there's no point memorizing the one now. People have realized that pediatric diffuse low-grade gliomas are clinically and biologically a distinct group of tumors. Here's the next thing with favorable outcome. There's a joke we have in surgery. It translates to everything. And so in neurosurgery, it translates to neurotrauma, neuro-oncology, everything. Generally, babies bounce unless they're too young. And that's the same thing. So if you catch them at the right time, they will always come back. You give them a chance, unless it's too young, where they might not even, they'll just go splat. So it's a bad joke, but now you can see this. I urge you to go read that paper. I put this here just so that you can see the MAPK pathway has been implicated as an abnormality in low-grade gliomas. So what that means is once we attack this with any medication, a treatment is coming soon. Everyone go, because now we know. Once you know what causes it, you know what to attack. This has been circled here. You think about BRAF mutation. I need to cite where this source is. This is the American Society of Pediatric Hemato-Oncology, ASHFO. They're the ones who put this thing right here. It's not hidden. This is from 2019. So someone is coming up with this. So in a few years, something is going to change. If we have a lot of them here in this country, why don't any of us sign up for any of the clinical trials? It's not hard to sign up for a clinical trial. You go, you're given a protocol, you follow the protocol. Go tell KNH, let's change the world. It's that simple. They don't even have to be a surgeon? No. Oncologist? No. They don't have to be even a doctor? No. You can even be a nurse. You know what to do, you write, you follow, you talk. They will ask you, you can be the lead as anyone. They will ask you to bring somebody who knows the thing on board. Why am I saying it like that? Because let's be very honest, there are only 15,000 doctors about for a population of 55 million. People are overworked, stressed, or they're just tired. They want to start enjoying life because they've read for over 15 years and they're not being paid well enough. So this is the thing here about the BRAF KIAA 1549 fusion, which reacts in activation described in 80% of low-grade gliomas, with the prototype being pilocytic astrocytomas. So if there are any neuros here and you want a high-powered study, I can imagine go get pilocytic astrocytomas from the KNH pathology department. They keep those blocks for 20 years. One of my colleagues, Dr. Ogutha, picked 6 cases of tuberculosis, and he went deep into genetics, etc., about the type that causes CNS TB. Very high-powered study. He only picked 6 of them from our thing here, and he traveled to Uganda. He was funded, and he did many things. Why can't anybody here do that? Pathologists, nurses, oncologists, anything. Just go find out if we have this here locally. You could find out ours is better next you start a trial of the medication. That becomes your life's work. Relax, do odd runs only when you feel like. Okay, so here's the other thing. So what does all the data say? The data says for those low-grade gliomas, gross total resection gives you a 90 to 95% 5-year overall survival. There's one thing I tell everyone when you start reading papers. Remember, and this comes from Prof. Joshi, whenever you read a paper, it's like seeing a woman in a bathing suit. What it shows you is exciting, but what it's hiding is vital. When we say 5 years, these are children. I expect children to live more than 5 years. So even when you're talking to the family, or if I'm not offering gross total resection, it's just 5 years. You need to think about it very seriously. The next thing for you to remember, there's a study here. I've written the study number. Go check. Wanatumia carboplatin and vincristine and comparing to TPCV for treatment of low-grade gliomas. This is what they found. 5-year event-free survival, 45% plus or minus 3.2%. 5-year disease-free survival. For those, so like those kids with the bilateral optic pathway gliomas, you use this treatment, only half of them will survive. Is that good? Is that bad? I don't know. You discuss with the family member. Okay, with that, I put a commercial break. Hopefully you can hear. So please pay attention to this. I think this is an example of how we resect low-grade gliomas, so you can have the picture in the back of our heads why neurosurgeons will pause and think sometimes this might not be exact science. So I want you to see how soft it is. It just looks like Uji. It's continuously bleeding. This is a young child. You just use the sucker, and it's done under microscopic magnification. So there you go. So what happens with the surgeon? They are feeling. They can tell what's normal tissue, what's not normal tissue. And then you get left with a space like that falls onto itself. Every tumor is different. The more you operate, the more you can tell, the more you can leave. Are there adjuncts to telling you what you can leave? Yes, but we will see that later. Now, this is another one. Now we take a deep breath. We've talked about low-grade gliomas. One of my other teachers, Dr. Diambo, used to say, brain tumors are always about real estate. So with that, I want you to think about this case that's happening. This is some case-based learning that we send to the residents, and just think about what it is. Oops, sorry. I was trying to pause it. Oh, sorry about that. I think we still have time. Okay, we still have time. That was a child who was preempting what this child is showing. Okay, sorry, it seems the way I'm sharing, I can't pause the video. So I'll read it over the sound. Hopefully that will be in order for everybody here. Okay, this is a 48-day-old infant who came with macrocephaly. The scan showed what looked like this big lesion. Everybody initially thought it was infection. But we asked for an MRI and we noticed that it seems to be some sort of dysembryonic tissue that was well-defined and mixed intraaxial, extraaxial. We did different images to see if it was going and pressing on the brainstem. And it's a large lesion which looks like it was more than half of the skull on a 46-month-old infant. So there's no plastic infantile ganglioglioma. What do you do for that? You just treat, you remove. They have about 14 years intervals before it comes back. The type of surgery is a straightforward parietal craniotomy. So why was that given? That was given as an example of sometimes it can look so bad, so scary, but with your knowledge, and the knowledge goes also to the neurosurgeon. Once you read beforehand, sometimes you can be slightly more aggressive if it's not infiltrating or disturbing anywhere else. And that will only be noted through examination of the patient, not from scans. So if you think you need to go back and examine the patient, that was the point of that scan. Other times, it can be sad even from the beginning. So you can get things like diencephalic syndrome. I put this here because though we've said rare, we've had 3 children with diencephalic syndrome in the hospital over the last 2 months. It's a rare condition, but a tumor located in the diencephalon, which basically means the control center, the one that's actively controlling and the subcontroller. And you get a child who looks like this. So what is this that you're seeing in the child? Look, then turn here. It's found in infants and young children. It has a rare constellation of symptoms which are hard to explain until you know. But they'll have failure to thrive, emancipation despite eating. Wanakula, lakini, they're just not growing. Their eyes move in things that don't make sense. They'll vomit and then they'll have hydrocephalus. So what that means is the thalamus and the hypothalamus is infiltrated. What does that mean? It means there's no way I'm removing all of that. Nobody is. Maybe an idiot is going to do it. But as soon as you do that, you have removed the patient. You will have a child who will be there in ICU for the rest of their life. You will have a family that will be crying. You'll be a family that's just paying for ICU stay every single day. How do you avoid that? A straightforward bad discussion, but you have to tell them. It's not us who give the patients the disease. We can only do what we can do. So the worst part about this is it's caused by low-grade astrocytomas. So pause and think about this picture. You have this, the tumor has been removed, child is sleeping, neurosurgeon's like, it's okay, I removed the whole thing. But then the child is just never waking up. You get the pathology, you're like, this is low grade, they've removed. Repeat scan, nothing. The child will still never wake up. Why am I saying that? Sometimes you see, especially in the MDTs, all the neurosurgeons just pause and they're like, this one, hatuwezi fanya. This is why. Even though they're saying it's a low-grade diagnosis, it's this. They can't. What can they do? Sometimes they can offer biopsy if it's amenable to biopsy, and that's case-by-case basis. The other thing you'll do is you'll give the same treatments that we give everywhere for low-grade gliomas. Have we said radiotherapy? No. Okay, next we move to high-grade gliomas. So low-grade gliomas, we're always going to try and do the most. We're always going to try and remove the most. High-grade gliomas, there's no point doing the most. Just relax. If you want the shortcut to high-grade gliomas, think of John McCain, God rest his soul. He had a high-grade glioma. What did he do? He had all the money in the world. He was in America. He could go to everywhere. He had a small eyebrow incision. They took a biopsy. They treated him. He got a couple of extra years, 3 to 5 extra years, because he was high functioning. They did not go and say, hey, let's give this guy a chance to try everything, because it wouldn't have changed anything. A high-grade glioma tends to look more well circumscribed and neater than the low-grade glioma that you saw. So they are malignant. They're either WHO 3 or WHO 4. They're aggressive. They're more common in adults than children. We thank God. They're more resistant to therapy, and they have poorer survival outcomes compared to low-grade gliomas. They're just sad. So in all of those astrocytomas, there was a part which was hidden here, which is high-grade gliomas. So if you want to change the world, focus on things for low-grade gliomas, how to treat them early, getting protocols. I've already told you, go do those genetic tests that you can do on pilocytics, then share with the world. All those things, your name will be there, you're a boss. Sawa. If you want to feel like more heroic, like you're fighting something, go high-grade glioma. It's going to be a sad story, but you will change something which will have significant, what they call it? It'll have significant clinical significance. Now, what are the things that cause risk, that increase? I'm so sorry, anecdotally, I'm very happy I found this graphic to put it here. Turns the dial up to 11. Sorry, I've said it, it's done. So they have increased risk of patients who've had exposure to radiotherapy, CNS leukemias, or previous CNS tumors. I told you, if you don't know anything, Leishmania is over there. Familial adenoposis coli, same things, brain tumors, tumors everywhere. Those guys have increased risk. Now, the goal is gross total resection. However, it's difficult due to the nature. I showed you low-grade gliomas. Low-grade gliomas, if you suck the Uji, most of the time, it's the connective tissue. You saw there were lines that stay there. Under the microscope, you'll see those lines. Those are the nerves that are there. If you're nice and soft with a good blunt sucker, you can suck around and you can preserve nerves. High-grade gliomas, they don't care. One of the things is cellular atypia. So that means it's going to spread through. Also vascular proliferation. So it's destroying. You see a high-grade glioma, it's destroyed farther than you can see. And with that, we call something called oncofunctional balance. You need to weigh removing a lot of tumor versus removing something the patient can do, a function of the tumor. So that's called oncofunctional balance. I believe there should be a video next. Good. Now, this next video will show you some of the things and the adjuncts that we use to maintain oncofunctional balance. I must confess, I did not save the one for the child. This is one of an adult who had a recurrent glioblastoma. Or the way that I cheated is this. This is a child. This is a patient who had a glioblastoma in childhood, represents the glioblastoma in adulthood many years after. So this is what we did. Dr. Magoha, and I'll be taking you through today's case, which is a left parieto-temporal glioblastoma. We present a 50-year-old female with a history of previous craniotomy, presents with a 6-month history of headaches, progressive hemiparesis, and sudden onset aphasia. Examination revealed a woman with a Konofsky score of 60%. GCS was 13, with right-sided hemiparesis, which was 2 out of 5 at the Medical Research Council grading. She also had a right upper motor neuron facial nerve palsy. A large, ill-defined temporal parietal lesion that was hyperintensive in T1, hyperintensive in T2, with variable gadolinium enhancement. It had elevated signal on diffusion-rated imaging. Choline, lactate, and lipids were increased, with a decrease in MAA and myonocytol on spectroscopy. From preoperative planning, we were targeting the superior temporal gyrus and inferior parietal lobule. We planned to do a standard temporal parietal craniotomy using the previous craniotomy line. We elevated the scalp in a single layer using the previous trauma flap. Good healing of the previous craniotomy line necessitated a new craniotomy using a high-speed drill. A cruciate craniotomy was done, exposing the superior parietal lobule, inferior parietal lobule, and superior temporal. During corticotomy planning, it was noted that the tumor was already pointing and egressing through the superior temporal. This diagrammatic representation shows the extent of subcortical resection we were planning. As the tumor was in the dominant hemisphere, we elected to use intraoperative neuro monitoring. The modalities we used were somatosensory evoked potentials, motor evoked potentials, and cortical mapping. Soft suckable regions of the tumor were resected by sucker dissection. The grittier and nodular regions were resected via piecemeal resection. Intermittent cortical mapping ensured that we maintained a good oncofunctional balance. We achieved a gross total resection. Post-operative imaging showed satisfactory resection. Preliminary histology showed nuclear atypia, cellular pleomorphism, evidence of mitotic activity with a diffuse growth pattern and microvascular proliferation, all features in keeping with a glioblastoma. Okay, so the patient had a recurrent glioblastoma. Now, the thing I said that I'll keep talking about is regarding classification. When you classify, you notice a few things. We've seen a very beautiful surgery being done. We have issues like time. So we have time to when we have to start the next point of care. So for anybody from any other cadre, for you to note, if you get a patient who has been operated on recently, if you don't know, and nobody knows everything, you can contact the neurosurgeon. It's a phone call. It's a simple phone call. Be like, hey, doc, this person was operated. When should they see someone? So as we start to make systems, some of you should skip the line. For some tumors, you only have 3 weeks until you start. For other tumors, you have 6 weeks. Now, what if there's a line? What if you're being booked? So some of them will have to skip the line. Otherwise, the money they spent, the time they spent is worse. Or here's the funny one. And I say this one to neurosurgeons. You can be so aggressive, but if your patient is going to spend 2 of those weeks in ICU, you've not really done much. The tumor is still coming back. If you want to know when, open the book, look at the typical recurrence rate that happens within 7 years or within 10 years. Then you are the problem. So if you think of that in the back of your head, those are all the things that the neurosurgeon is trying to calculate when they decide what to do. It's not as simple or as straightforward. It's not, I'm not talking down to our oncoplastic fellows or anything like that, but it's not like breast. It's not this. It's like, oh my gosh, the breast is this. Where do they live? How far can they do this? What can they do with this? What can they do? Can they move their hand here? What can they do this? How much am I supposed to resect? What can I do to help me in surgery? So that's how the neurosurgeon is thinking all the time. Okay. All right. So now another molecular feature. So if somebody wants another study that they want to do, there's a molecular lab down there. Go find out how much it costs. Talk to the pathology people. You don't need many. You need maybe 5, 6, 7, 8, 9, 10. Then you find out, is this other mutation, H3K27M? Now with that, and this other histone mutation, which is H3.3G34R, you can take a picture of this. With those two, we have a target to treat. Once you have a target, then we're getting closer. So it's a good sign. Classification will change and start adding these two things. This is a H3, K2, what M, mutation, etc. The other thing which comes here is you could have high-grade gliomas in the worst places. And a typical example is DIPG. I think I'll put some information on DIPG before the end of this. DIPG is one of the worst things. It's an infiltrating tumor in the pons. Diffuse infiltrating pontine glioma. It's one of the worst. It looks like you can do something, but there's nothing you can do, Rosafi. It's spreading through, the pons is the bridge. Once you do something there, you cut off the entire upper brain from the lower brain. You give patients things like locked-in syndrome, one of my personal fears. They can hear you, they can see you, they can just never respond. They can't move their eyes. They're just stuck like this. You think they're not there. Afadhali, those who are stuck with their eyes open. Imagine you're stuck with your eyes closed. You can hear everybody talking about you. You can move for the rest of your life. You're just being kept alive. That sounds like a horrible life. I wouldn't wish that on anybody else, on anybody. So you need to understand this. Sometimes when you're being told no, you're being told no for a reason. Okay. Then the same thing comes. Now, for low-grade gliomas, removing the tumor is the best thing. If you can't remove the tumor, you can give trial of chemotherapy, some plus or minus biopsy. Now, for high-grade gliomas, remove as much as you can safely, then you will always, repeat after me, always send for radiotherapy and chemotherapy. If you remember that, that's fine. But we're talking about kids here, so there's a caveat. Sometimes there's some kids you can't send for radiotherapy. So those are children normally below 3 years of age. The protocols will keep changing. This is out of my purview. All I can do is advise and say, what are the risks? Things like whole brain radiotherapy will already prevent less than 3 years of age. You're still going through a secondary development of the brain, which starts about 18 months and will keep on going. You know that development of the brain stops at about 25 years of age. So there won't be 100%. So, and that's a significant thing. You don't know how far below 100% they will be just because you put radiotherapy, but I'll defer to our radio-oncologist to talk about that. Here's the problem. This is the reason why everybody knows about glioblastoma or high-grade gliomas. But it goes to the first thing that I told you. It's universally poor. Glioblastoma is the one that everybody says. When I started my residency, all over the world, the longest people were expected to survive was 3 months with the radio and chemo. And then it used to happen to people at about the age of 35. So believe I was scared. Hey, when I was turning 35, it's going to happen. It's going to happen. It's not. Amen. So universally poor outcomes. The news is good now. Now we've moved from 3 months to about 58 months with the current standards of care. So what you're talking about is quality of life for a glioblastoma. The next thing is we've realized it's not one entity. There are multiple different entities based on everything like MGMT status, methylation, all those other things you'll be able to prognosticate the patient. What am I telling you? After the tumor has been removed, you might go to the pathology multiple times to change the treatment. Now, anecdotally, everything I'm telling you is things published. I hate saying the West. I'll say exactly what I mean. Published on white guys. We know we're not the same as white guys. Anecdotally, any neurosurgeon who is practicing here in this country, you have seen patients who they couldn't even afford chemo or radiotherapy, but they're coming 2 years, 3 years later. What is happening? I don't know. I don't know, but you have to make noise. The oldest I've ever seen, and I remember so clearly, I got sad, then I got happy after, was a pastor who was diagnosed with glioblastoma. It was 15 years ago. It came back as a recurrence. He was even treated with CCNU. What was funny is the report didn't even write glioblastoma. It wrote the old name for glioblastoma. We even had to go and look for the blocks to see if it was actually true, because it didn't make any sense to me at all. So there's something happening here. I don't know. And that's the same thing. There's unique biology in both infants and children. There's a paper that we published with Dr. Musa. I urge you to look for it. I didn't put it here because I didn't want to overplug myself too much. Or did I put it? I did put it. So this is here. This is an infantile glioblastoma multiforme. This is one of the rarest presentations. Fun fact, I tell everyone here, I hope you realize every time I'm talking about the people I started with, and we will continue together. One of them is Dr. Kitungu, who was my classmate, and we also share one of the offices together at the university. What's funny is he got one of these, and then a few weeks later, I got one of these. I didn't tell him about mine, he didn't tell me about his. If we spoke to each other, we would have had one of the strongest papers there. This is published at the East African Medical Journal. It shows you how rarely they can present and spread through the brainstem and different things here. Everybody here, you know, this Dr. Omar is now a neurosurgical resident. Dr. Musau is a consultant. Dr. Thabo Lurand is now known as Professor Luranda in University of Botswana, and then there's myself there. Okay, now with that, I think you're a bit overloaded. Let's recap. We've talked about how they present. The investigations, you've generally got how they are. We've talked about low-grade gliomas and the problem with surgery. We've talked about high-grade gliomas. Now I'll give you a few specific examples of the most common ones, and we'll start with this one. Greetings. My name is Dr.
and today we'll be discussing ependymomas. Ependymomas are non-invasive, slow-growing tumors that arise from the ependymal linings and may protrude into the ventricles. They may occur anywhere along the neuroaxis. In the pediatric population, they're mostly seen in the posterior fossa, and in adults, they tend to be intramedullary spinal cord lesions. Ependymomas comprise about 5% of all brain tumors, with approximately 69% of them occurring in children. However, they only comprise about 9% of all pediatric brain tumors. In regard to the spinal cord, ependymomas account for 60% of spinal cord gliomas, with 96% of that occurring in adults. Ependymomas have the potential to spread via the cerebrospinal fluid through the neuroaxis via a process known as seeding. This results in drug metastasis. This occurs in about 11% of cases and is more common in higher grade ependymomas. Systemic spread is only reported in rare cases. These tumors are classified as ependymoma, which is WHO grade 2, or anaplastic ependymoma, which is WHO grade 3. However, there is no association between histologic grade and both progression-free and overall survival. Therefore, WHO grading is rarely useful for treatment stratification in ependymomas. Molecular subgrouping is superior to histologic grading for risk stratification and treatment of ependymomas. So how do they present? Symptoms are commonly due to the posterior fossa mass, which results in increased intracranial pressure with occasional cranial nerve involvement. The symptoms of increased intracranial pressure reported are headache at 80%, nausea and vomiting at 75%, ataxia or vertigo at about 60%, and lastly, seizures that occur in only 30% of the supratentorial lesions. The common signs are due to invasion of the floor of the fourth ventricle, affecting the facial colliculus, which is the genu of the seventh cranial nerve, as it deviates posteriorly around the sixth nerve nucleus, thereby causing both facial and abducens nerve palsy. How do we evaluate a patient with a suspected ependymoma? In an emergency, a CT scan of the head can be used. However, these are not detailed and are not very useful in evaluation of the posterior fossa. A contrast MRI of the brain is the modality of choice. Ependymomas usually appear as a mass in the floor of the fourth ventricle that may cause obstructive hydrocephalus. A spine MRI is also needed to evaluate for drug metastasis and sugar coating. So, treatment. Surgery is the primary form of treatment for ependymomas, with gross total resection being the most important prognosticator for overall survival. The goal of surgery is maximum safe resection without causing any neurologic deficit. Gross total resection may not be possible when there is invasion of the floor of the fourth ventricle. Aggressive resection will result in bradycardia. A lumbar puncture is done 2 weeks postoperatively to look for drug metastasis. Ependymomas rank second only to medulloblastoma in regards to radiosensitivity. Therefore, radiotherapy is administered after surgery, and this increases 5-year survival by up to 40%. Cranial radiotherapy is given at about 45 to 48 grays to the tumor bed, or 59.4 grays using 3D conformal radiotherapy to the tumor bed with 1 centimeter margins. Spinal radiotherapy, which is low dose, approximately 30 grays, is given to the entire spine when drop metastasis is identified. You also give extra boost doses to the regions with the drop metastasis. Prophylactic spinal radiation at present is controversial. Radiotherapy is generally avoided in children under 3 years of age and reserved for treatment failures. The role of chemotherapy in epidermomas is extremely limited and reserved for only selected recurrent cases. Thank you for your attention and have a blessed day.
Now, why did I put the whole video there? I put the whole video there for you to realize it's more than just the surgery. Even after the surgery is done, you saw we kept talking for a long period of time, and that changes with the diagnosis. So here's the thing. As the systems keep getting better, there is no shortcut to knowing the histologic diagnosis and then the molecular subtype. So now we're moving on to molecular subtyping, and that's the work with the pathology department that we have here. And with that, the treatment will keep getting better and better. So that's what everybody needs to advocate for. Even though the surgery has been done, if you hear anybody has had a brain tumor, it's then what? Then what? As any medical professional, then what after the surgery? I think there's one more example, which should be shorter this time. Uh-oh. After we finish, we will have questions. So this one should be shorter.
My name is Dr. Magoha, and today I'll be taking you through diffuse intrinsic pontine glioma. Diffuse intrinsic pontine glioma is an aggressive type of childhood cancer that forms in the brainstem. They are very rare and almost always occur in the pediatric population. However, they have been described in adults as well. To avoid the high morbidity and mortality associated with this condition, DIPG must be promptly diagnosed and treated, because regardless of its histopathology, it follows a malignant course. More than 2/3 of brainstem gliomas are DIPGs. There are many theories on how these form. However, one of the most accepted theories for the development of DIPG is a mutation of the H3 gene, in which mutations in the N-terminal tail of the histone H3 gene have been found in midline pontine high-grade gliomas at a high frequency. The H3K2 mutation and loss of the H3K2ME3 are of paramount importance, since it likely represents the first genomic event leading to the transformation in these tumors. The classic presenting triad in DIPG is only present in about 50% of patients. This includes long tract signs, cerebellar signs, and cranial nerve neuropathy. The clinical course for children with DIPG is rapid. Most symptoms start less than 4 weeks before seeking medical attention. The symptoms are caused by dysfunction of pontine structures, including the long tracts and cranial nerve nuclei. Diplopia is usually the first sign, which is secondary to abducens nerve palsy. Damage to the facial nucleus will produce facial weakness or paralysis, and damage to the long motor tracts will produce weakness and hyperreflexia. Dysfunction of the cerebellopontine connections will cause ataxia, dysmetria, and dysarthria. Diagnosis can usually be made radiographically through MRI. They have a diffusely expanded pons at their epicenter, which extend into the medulla or the midbrain, and lack a focal or an exophytic neck. Engulfment of the basilar artery is commonly seen in these tumors. Biopsy is generally not recommended because there is a high risk that a biopsy procedure would cause additional neurologic deficit. Also, biopsies generally have no effect on the patient's treatment, which consists mostly of palliative chemotherapy and radiation. Prognosis is generally, unfortunately, dismal. Thank you for your attention and have a blessed day.
Now, I put that second case for you to realize that sometimes, that's just one example, there's absolutely no point in biopsying the patient. It will just be an academic exercise that would make the surgeon or the doctor feel better. In cognitive biases, that's known as action bias. If the fact that you feel that you've taken an action, you think you've done something. Not in all brain tumors, and DIPT is the perfect example. But one day that will change, amen. All right, now a parting shot. The next thing is I'm going to speak directly about our facility and the ways we can move forward. Now, in neurosurgery, we need to move away from this thing where the neurosurgeon was all onto himself. When it comes to things like neuro-oncology, we have integrated care pathways, and what we call it is it's mapping, or it has different words, where you walk people through the journey in different sections. So with that, as we move forward, we need to start discussing different places. We need to have nurses who will know to call the patients. You need to have oncology nurses who will know to follow up the patients and check. For example, if you have a patient who has a brain tumor that's been removed, there should be somebody from another section that will either come tell, or somebody from the section would be like, hi, this person is supposed to have radiotherapy within 3 weeks because of this tumor, or 2 weeks because of this tumor. So how does that happen? It means histology has to go to pathology very, very fast. It means it has to move faster, especially for children. So you don't wait for the usual, this is 4 weeks to 6 weeks. This must jump the queue. If it's something like, I've gone on breast a lot, even colorectal cancer, if it's something that can wait, before you start giving radio and chemo, then let them wait. Let the brain move faster, because if you miss that window of 3 weeks, 4 weeks, there's nothing we're doing except treating ourselves. So all that is integrated care pathways. This is a nice study that anybody who is in charge of anything can read. We can start our mapping at the hospital and start deciding what are the things you want to take care of. If it's low-grade gliomas, we just start mapping for low-grade gliomas. The next thing is, the best thing about being African or being Kenyan is we're nice. We're a young population. We add our own things. What are our patients suffering from? Do they have places to stay? Is it that somebody comes all the way from Lodwar and they have to come here for chemotherapy and radiotherapy? What can we do to help them be better? Then we need to start thinking about public-private partnerships, see how we can keep moving forward, so that if somebody gets a tumor, and the way I like to say it, a brain tumor is the simplest thing for you to understand. It means somebody was just at home and one day they got something they never planned for. They never planned for, we don't know why it happened, it just happened to them. And if you know that, that can happen to anybody, including you. Now, what are you doing as a medical professional to help that streamline that whole thing so that it's better? And once we have the system, everybody's just going to benefit. So we need to start looking at this as well. And as I said, remember why we do this. This is a very good source for you to read. If you're ever confused as to how a brain tumor patient wants to be treated or what they want to do, this is in the IBTA, The Rising Tide Lifts All Boats. Go look at the Brain Tumor Charter of Rights. These are rights which have been written by surgeons, by people who suffered brain tumors, people who are about to die who have brain tumors, those who have survived. And they tell you the couple of things that anybody who knows anyone who has a brain tumor should be aware of. These are the rights that people want. They want autonomy. They want you to talk to them like this. Don't look down and don't be like, oh my gosh, things are so bad. Don't lie to them. These are the things that they themselves want all over the world. So if you don't know what they want, just read and start treating them like that. So remember why we do that. Thank you all for your time and thank you for your attention. If you have any extra questions past the question and answer section, that is my official email address. If you want to see me again, you can follow me on all of those platforms. This is my most recent academic-ish book, Study Like a Surgeon. If you want to see the other ones, you can read about focal interest cranial suppuration, which I've written about, amongst other non-medical things. But this one seems to be good for the students, residents, or anybody who wants to learn how to read quickly. At this time, I defer to my chairman or chair lady, and then we move on. Thank you for your time. Are there any questions, or should I, Dr. Nzamo, I believe you'll take over from here?
Yes, Dr. Magoha, thank you very much. We appreciate that. You demystified very well. Thank you for the visuals, the videos. You've made us understand. And I just want to encourage the audience. There's so much more. Please register for the workshop so that you can be able to learn more when there's adequate time on the brain tumors. Dr. Magoha, there are some questions that are just for you. We've answered about 60, Sarah and myself, the ones that we called. Now,
Wow.
the ones that are reserved for you, the first one, an attendee is asking, thanks for brilliant presentation. How do you decide between CSF shunting procedures in patients with brain tumors, that is EVD versus ETV versus VP? Is it dependent on tumor location? And number two, what's your comment on neuroplasticity in the context of brain tumors?
Okay. Those are both very good questions. Let me start with the first one about CSF shunting procedures, and I'll keep it very simple. Number one, is there a need to shunt the child? People need to understand a shunt is not a temporary thing. A shunt is forever. So ideally, most of the time all over the world, we do not want to shunt a child who has a brain tumor unless we are forced to. I need that to be very clear, unless we are forced to. So most of the time in most facilities, we will put something like an EVD. Now, when you do like a SWOT analysis and we think about it, some things don't make sense because of use, like economies of scale. The average EVD costs about 85,000 Kenya shillings, 25,000 to 85,000 Kenya shillings, depending on the type that you're using. Does it matter to the surgeon? No. But average shunt costs between 3,000 to 8,000 Kenya shillings. Keep in mind, we live in a country where the average monthly wage or turnaround is 20,000 shillings. So what will end up happening is, because of where we are, we might be forced, and we might be better at putting in things like ventricular peritoneal shunts. But if you're in a facility, or if you're in a place where money is not an object, then the surgeon will probably tell you to put an EVD, which will cost a lot more. It's a temporary procedure, and you can remove it. That being said, about 5 to 8% of children with tumors might need a shunt during follow-up. Now, to answer the part of ETV. ETV is endoscopic third ventriculostomy, where you go to the floor of the third ventricle and you make a hole that will go to the interpeduncular cistern. Now, that can only be done if all of those places are available. Most of the scans I showed you, something is growing through the ventricles, or worse yet, the interpeduncular cistern is not available. So an ETV would not be there of choice. I say that because every now and then you get somebody who's read and says ETV. In some, it can be done. Others, it can't be done. Right. So I hope that answers your question. And in cases where you have time and money, the surgeon will do all of that as part of the procedure. So if, for example, a posterior fossa tumor, they will rush you in. They will put an EVD over here posteriorly, close to the incision line, and then they will remove that either immediately after theater or in theater. And you might not know that they did that. So I hope that answers your question. The second one was, sorry, remind me, Dr. Nzamo, was? Neuroplasticity.
Neuroplasticity in the context of brain tumors.
Okay. Those are two very nice, beautiful things, and you're literally on the cusp of when you know research. So if you're a medical professional, please go and Google glioma connectome project. And what the glioma connectome project has done is it shows you that what we thought about the brain is not exactly the way we did. I'll say it very quickly. We only know the brain does different things because of blood flow to the brain during functional MRIs. And that's simple for things like moving my hand, moving my fingers. But what happens in more complex things, like what I feel about myself, motivation, anger, and this. Even that we can map now. And what is noticed, depending on the type of glioma, it doesn't seem to affect the thing itself. It doesn't affect the circuit. It displaces the circuit. So you will find now more and more surgeons, based on things like that, Connectome projects, will be asking for things like fMRIs, tractography, diffusion tensor imaging, and they'll be asking you what would sound like weird questions. It's because they want to see, have you lost this already, or will it come back? For things like low-grade gliomas, they're displaced. For things like high-grade gliomas, it is destroyed. And if it's destroyed, will it come back? Nobody can tell you that. The project will let us know. But that is a good question. Okay. Right.
Okay,
Any other?
thank you. Yes, there are still a few more. Who basically Asumin is saying excellent presentation, but then a lot of the comments were about the excellent presentation and appreciation. Asumin says, I was privileged to view post-op neural head CT and MRI in patients in Zurich, which had minimal or negligible post-op complications. However, our post-op complications are worrisome. What would you attribute this to?
Okay, number one, that's a generalization, because I literally just showed you videos with post-op data. The only thing is, given the forum, and this is not a purely academic forum, there might be non-academic people here. I cannot show videos and pictures of patients that are okay. The one thing I can tell you is this: anything that I have shared here, I have permission to share it from the person who has undergone this. So that being said, and in surgery, we say the best thing about surgery, you can't talk your way out of it. Outcomes will show who you are. And the outcomes are good. So generally, let's get away from this narrative, because here there are very few surgeons. There are about 35 or so who are registered, but coming up, there'll be about 60 or so. The reason I say that is most of them are not loud. I am naturally a loud person. I will share, I will say, when it's normal for people to hear what is bad or what is going on. What I can tell you regarding neurosurgery, and if you look, as I've shown you the publications, I've shown you what's going on, I've shown you the videos, people come here for training. We are regarded in very high regard. We have international conferences where people come here. They come to Kenya. The same people from Zurich, if you tell me the names, they probably were here at Radisson Blu. So I think we need to get away from that narrative that it's always better outside. We need to be very specific. But when it comes to brain tumor care and glioma care, we're at par, if not better. And that's from them, not from us. And all of that you can Google and find out yourself. So I would say just be aware. The only other thing, if I'm being very honest, you need to be aware of here locally is there might be people pretending to be neurosurgeons that are not neurosurgeons. Either locals or internationals. And that I can't speak about.
Thank you. That's a great answer. Thank you, Dr. Magoha. Dr. Chana asks, he has a question about modalities such as intraoperative functional MRI or neurophysiologic monitoring involving tumors in functionally critical zones to aid intraoperative decisions and minimize injury to normal tissue. Maybe frozen sections for margin assessment. What's your comments on that?
Okay, everything he said apart from the MRI, I have shown you a video.
Yeah.
So everything you talked about, the integrative neuromonitoring, the reason I talk about cost is so that people can be aware that it is something. So we shouldn't shy away from it. Intraoperative neuromonitoring costs about 10,000 shillings at Kenyatta National Hospital. There are private partners that do it there. They want to help other people. So that is standard. We have everything, SCCPs, MEPs, everything is there, cranial nerve monitoring. In the video that I showed you, it's right there. I even said it. So that one is there. The other one that you talked about is frozen sections. We are able to do frozen sections. It's on the onus of the resident to be aware, and then we decide. The next thing I need you to be very aware of, neurosurgeons are like, the best example would be like mercenaries or race drivers. They know what they want to use. They can use whichever gun they want to use. Sometimes their skill might transcend that and it will help. For example, if it's a low-grade glioma in a non-eloquent area, which I can tell on a scan, I don't need to spend extra money on you doing a frozen section. If it's a high-grade glioma that I'm not too sure about, if it's already clearly a high-grade glioma, where am I? What's the point? Just like the DIPG. So in selected cases, we do them, and if you have the recording, you can look back. It's there. But that is a good question. The one thing we do not have now in the country as of yet, and that needs significant infrastructure overhaul, and I'm sure one of the new hospitals or theaters will do it, will be intraoperative MRI. That being said, we do have neuronavigation available at multiple facilities within the country, and that will offer almost the same thing. And before you say it, if you're a neurosurgeon, yes, we do account for a shift of the brain with neuronavigation. That's an excellent question.
Thank
Anything
you so
else?
much. Maybe just one more. Is there any truth in the theory that sleeping with light predisposes one to brain tumors? That has been asked by 3 people. So I thought it's good to hear it from the experts. And finally, there are several questions about how can we get your book, Study Like a Surgeon. Yeah.
Oh, okay. I'll give the number of my clinic, which is good. That means I also get to advertise. Yeah. My secretary will organize with you.
Okay.
If you have time, it is 0715 476 805. So just give a call if you want the book. Keep in mind, it's a small book meant to fit inside your lab coat. Yeah, and it's exercise that you're supposed to practice. Now, the other thing, the other question was sleeping with light. Remember, I showed you the first slide, and I need to be very honest with you. We do not know. I don't know. I don't know. The only one that we know for sure are genetic predisposition and ionizing radiation. The one for ionizing radiation, which I could tell you, is not light, but it's the one thing everybody has. And it's even in the thing all of you have on you right now. It's your cell phone. So things like sleeping with the cell phone, etc., they're kind of implicated, and it changes depending on the model of the cell phone, the size of the battery, etc. Just keep it away from you. It's common sense. It has lots of ionizing radiation. That one, if you go Google, it's half-half. We don't know why, but the way I think about it, if it's half bad, that's still bad. So that's the one for light. I don't know. So I can't lie to you.
Wow, thank you so much, Dr. Magoha. Indeed, we've spent our time well. It's 10 minutes past. It's 3:40 now. Lots of appreciation messages, lots of thank yous. We've had 1,800 participants, everyone really appreciating. So we look forward to meeting again at the workshop. Guys, please register. The link is there. Those who need the book, I can repeat the number. It is 0715 476 805. Thank you everyone for attending and have a lovely afternoon. Thank you, Dr. Magoha, once again. Bye everyone and have a good evening. Thank you.